Some questions.
Okay, thank you very much. A comment first. Thank you very much for the presentation of Dr. Albin Musa. I enjoyed that you mentioned and you used the words favorable and unfavorable rather than suitable and unsuitable, because for most people, if something is clippable, then it doesn't make necessarily the patient being a candidate. For TER, is all the information you need from echo, just from ultrasound, or because I understand that for transcatheter, TMVR, and for MAC, we need a lot of information from the CT. Do we need a CT, or TER can go ahead only with information from echocardiography?
Microphone.
So for the mitral valve tier, I would say 2D and 3D should be enough data. I never used CT for such a procedure. I don't know if any on the panel has a different experience.
Ο κύριος Δανιάς.
I think this morning we really have experienced a great group of speakers and amazing lectures that have encompassed the whole spectrum of mitral valve surgery and procedures of the mitral valve. Certainly very complicated and difficult to deal with structure. I think what needs to be understated is underlined, is that we need very good imaging, understanding of physiology and pathology, anatomy as well, and therefore we need very good imaging of the mitral valve. Certainly echocardiography is the most important tool that we have, transesophageal, intracardiac, and 3D echocardiography. CT also for the understanding of exactly where the mitral calcifications are. And I would also dare to add MRI as a means of understanding the physiology, measuring the exact ejection fraction, understanding and measuring the regurgitant volumes and fractions. And so integrating all these imaging modalities would give the interventional cardiologists and the cardiac surgeons the tools to understand and best plan their procedure. Really, thank you to all the speakers in the audience.
Thank you, Dr. Danias. Dr. Niños, any comments or questions?
Short question to Dr. Sparias Kostas. Which is the good candidate to put a valve in MAC?
I would say non-Ilias, but if everything else is exhausted, then you should have a very good pre-analysis, CT scan, screening, satisfy yourself that the sizing is okay for the valve you're going to use. Satisfy yourself that the calcium is distributed in a symmetric way. Try to predict that your valve, when it expands, it will go where you want to go. And finally, make sure you're not going to have LVOT obstruction. So I think if you do all this, if you apply all this, very, very few candidates will be good for valve in MAC as we're doing today. But I think that the valves that are coming, like the M3 valve, I think it'll be easy to implant because it will also pull the leaflets with that dock that I showed you earlier, inwards. So I think the LVOT obstruction problem will be very rare. And a testament that this is true is that this study completed recruitment very, very easily. So the inclusion rate was like 75%, when the inclusion rate in all the other devices is like 20% or 15%. And then you have to say, if I'm going to use a valve that is only good for 20%, what's the point?
Ευχαριστούμε, Κώστα. Thank you, Kostas. And we couldn't have a better session with our eyes towards the future, the vision, the progress. And let's finish with the two friends, heart surgeons, that I have with one question to both. Having a patient 75 years old with history of rheumatic disease and the regurgitant mitral valve, and the echo shows the restriction of the posterior leaflet, what would be your criteria for replacing or repairing the valve? Rheumatic disease, restricted motion of the posterior leaflet. We start with Adonis. Well,
75-year-old, if the patient has got commissural fusion, that it is, I would go for this as well. Restricted posterior leaflet motion, I wouldn't trust it as a sign of rheumatic disease. But if there is fused commissures, then it is indisputable rheumatic disease. Then I would go for a bioprosthesis. If the commissures are not fused, then I would very much question the diagnosis, and I may consider a repair. If the coaptation depth is above 10, I would still go for mitral valve replacement with a bioprosthesis. With a lesser coaptation depth, I would attempt a repair, but most probably the patient that you describe is for mitral valve replacement endoscopically with a bioprosthesis.
Thank you, Tony. Dear Theodore, your opinion, your approach.
Yeah, I totally agree with Adonis, and the devil is in the detail. I mean, how high is the posterior leaflet? What portion of it is mobile and what is fixed? Which scallop exactly, fused or not fused commissure? So it all depends on that. But 75 years old, let's say if it's tethered and immobile entirely, I'm not a friend of augmentations, even though it occurred to me before, and I extended the leaflet a bit and it worked. But it's not the everyday case. So I would retain the posterior apparatus to the extent I can and throw in the biological prosthesis in this patient.
Thank you very much. With thanks to all of you, especially to Theodore, who is the far distant away. I hope the weather is good there. Theodore?
The weather is good, but I missed it. I was in a redo case today all day, so...
Okay, looking forward to see you here. Adoni, Vlasi, and Kostas. Thank you very much for this very, very nice session that we had, and even on time, given the fact that we started 10 minutes late. Thank you very much, all of you. Thank you.